Welcome to BioBalance Healthcast. I'm Dr. Kathy Maupin.
And I'm Brett Newcomb. And today we're continuing our conversation about incontinence in women postmenopausally who have had vaginal deliveries of children.
Yes.
In the previous podcast we discussed that. We kind of got deep into the weeds in that discussion and ran out of time. So we'd like to continue that discussion. And today we want to start with revisiting the concern about irritable bladder as opposed to stress-induced continence, which is for those women when they cough or laugh or lift a heavy weight, that's a stress event that causes a urine leakage.
It's a gravity event. Rarely do they lose urine when they're lying down. They could, but rarely. But there's two kinds of incontinence that bother women of this age. So the stress incontinence is one that has to do with babies and has to do with heavy lifting throughout their life and other things that put pressure on the pelvis. But the other type is called irritable bladder. Irritable bladder is different. You don't lose urine when you're lifting something, but you may be just standing there talking to somebody at a cocktail party and your bladder spasms and you've wet your clothes. So it is related to nothing. It's just irritable. Some women get this once in a while. It's still embarrassing. I don't care.
Is that a nerve problem?
It can be. In fact, they've gone through all of the different research on what causes this.
Yeah.
And in general, it can be a nerve problem. People who have MS, people who have neurologic abnormalities in the peripheral nerves, meaning the nerves not in your brain but outside, is a peripheral nerve or outside around your pelvis. So that can cause this. It can also cause, the neurologic problems can cause retention of urine, which is an even more difficult problem because you can't empty your bladder. So that's a separate issue. I'm going to table that because that's so extensive. It could be an entirely different conversation. This is about women without other medical or neurologic diseases that just all of a sudden their bladder's spasming all the time. They can't get on a plane.
Right.
They can't travel. They can't get in a car and go on a car trip. They have to stay home. And it's really horrible because there's no lead up. You don't get a sign it's going to happen.
Right.
It just spasms and there it is. And you feel it right at the time that it comes out. Now I've talked to women about this my whole career of being in gynecology, and I talk to them about it now with hormones because hormones do help this condition. Now, the way I tell the difference without doing a test between stress incontinence and irritable bladder is I ask them when it happens.
Right.
When they notice.
What are you doing?
What are you doing?
Yeah.
I mean, if they say, I'm doing nothing, I'm not lifting, I'm not coughing, I'm not doing anything, and it can happen when you're sitting down, it can happen when you're lying down.
Okay.
It doesn't require gravity to cause it. So I then divide these two things up, and generally a urologist can do surgery on the stress incontinence, but a urologist shouldn't be doing surgery on irritable bladder because it doesn't help. Okay? Irritable bladder.
The surgery for the stress incontinence has to do with the length of the urethra.
Yeah,
or
lifting the bladder up.
All right.
Everything's fallen down, and so they're lifting the bladder up. Sometimes gynecologists have to take the uterus out for stress incontinence because the bladder's dragging, or the uterus is dragging the bladder down. So sometimes, but that's a surgical thing.
Right.
And by history, you can usually tell which is which. We also have at our disposal a cystoscopy where you can look inside, and sometimes you can look inside the bladder and see if the urethra is straight and if the bladder's fallen, or you can see if the lining's irritated. And with irritable bladder, the lining's irritated.
Right.
It looks kind of reddened and irritated and swollen. It is an issue of not neurologic issue in general. It is an issue of the urine is now irritating the lining of the bladder, okay? So that's
the
what
pH
hormones,
factor, the acid in the urine.
The acid in the urine is irritating the tissue.
The bladder.
Well, you're able to void the bladder all the time. You're losing urine all the time, but the reason you're losing it is because the lining of the bladder is just contracting in response to irritation.
Okay.
So that is something that I get to treat, and I treat very well, because testosterone and estrogen both thicken the lining of the uterus and make it normal again, just like when you were younger. And so that lining thickens up and has a covering that is protective. So what happens is, you get that back within a month of getting pellets or starting therapy.
So it's like an electric wire that has that rubber coating on it, and the current can run through the wire and you don't feel it. But if there's a breakdown in the coating, you'll get shocked.
Right.
And so you get shocked when the urine is forced out.
Yeah, you get shocked, and
because those
and the
nerves
bladder's
are sending current in response to the acid in the urine.
Yeah, they're very superficial then, instead of being behind a thickened covering.
Yeah.
So this is, if there are any doctors out there, yes, this is simplistic on how I'm describing this, but
remember, she's explaining it to me. I grew up in Arkansas.
But it is a way of explaining why hormones work. Now, again, I didn't really think about that when I started doing hormone pellets, testosterone and estrogen. I knew estrogen worked, because when my whole career, if somebody had an irritable bladder, we gave them estrogen cream, like Premarin cream or Estrace, and we had them put it right on the urethra, because the bladder and the vagina are responsive to estrogen. So we use local therapy by putting estrogen cream right on the opening to the bladder, and it actually helped thicken the urethra so that it was resistant to bacteria. Because another thing people get with this irritable bladder is infections all the time. They don't have a covering. Now I'll describe it as you're wearing your raincoat with your hood, and they don't have that raincoat on. They're just wearing their cotton shirt out in the rain.
Right.
So anything is going to irritate this. Bacteria goes right up into the bladder and causes infections all the time. So
bacteria goes up into the bladder.
In general, it doesn't.
When women intend to urinate or do urinate and they clean themselves, there actually is a recommended way that mothers are supposed to teach their daughters.
Right.
This is the way that you clean yourself.
Right, and you're supposed to wipe front to back or front to back.
Okay, because if you don't, you're dragging bacteria directly
from the rectum
to the urethra
into the bladder. So you should always wipe front to back. That's one thing, and that I found doesn't always get taught anymore.
Yeah.
When you're wiping a baby who's a female baby, and you've only had male babies, you don't know that you're supposed to wipe front to back.
Yeah,
and if you do it the wrong way, then your baby gets infections all the time.
Yeah.
And babies don't have a lot of estrogen, and so, of course, I think if you did that to anybody, you might get infections over and over again, just because that's not how it should be done. But you're putting yourself more at risk. The idea is always wipe front to back, always wash and urinate before and after sex, because sex also can push bacteria into the bladder. Now, this is anybody, not just people
not just women over 40 that have had vaginal delivery.
Right. This is everybody. And intercourse does increase the risk of bladder infections. So a lot of times when my patients get their libido back, they come and they go, oh, I'm getting bladder infections now. And I'm like, oh, well, it's working, but you need to.
So then you have to have the conversation with them about sanitary practices.
Right. Wiping and urinating before and after intercourse. And if that doesn't work, then oftentimes I give them a very mild antibiotic to take every time they have intercourse, just to clean out the bladder each time, because it's not good for your bladder to get infected all the time.
No.
So that's even with hormones.
It's hard to be a woman. You have so much more you have to worry about.
It is very hard to be a woman.
Yeah.
And you're just finding this out now?
Yeah, well, I didn't have daughters.
That's right. There's all these little details.
And I don't know that I would have discussed with my wife, do you always go urinate before and after sex? You
would notice, though.
Maybe.
Maybe.
If I hadn't fallen asleep.
Okay, well, all right.
I'm pretty focused when that happens,
and
it's a very limited focus, so I don't know.
Okay. Well, now that the women and the men listening can at least recommend that, it saves you money on antibiotics. It saves you going to the doctor. It saves you all kinds of things.
Well, and that whole lifetime exposure to antibiotics issue.
Right, I know, and we don't want you to be resistant to antibiotics, so it's much better to prevent an infection if you can. Back to what happens when you don't have any hormones.
Okay.
When you don't have any hormones on your bottom, you get old lady bottom. Women do, not you. Anyway, women get old lady bottom,
Good.
meaning...
I was going to have a change.
I know. Women get old lady bottom, meaning their vagina gets very narrow and not stretchy. You can't bring it back to life by stretching it because the tissue is very fragile. If they have intercourse, it tears. It's like tissue paper. So instead of having nice thick skin that can withstand intercourse and sitting on it all day and urinating, it is affected by everything. So women who don't have estrogen have a lot of bladder infections and yeast infections, and it's itchy.
So if a woman's coming in with a complaint about frequent yeast infections, is one of the first assumptions you make that she doesn't have enough estrogen?
Yeah, yeah. You have to kind of look at that.
Yeah.
You have to look at the bottom, and if you've seen an old lady bottom, you know what they look like.
Well, I actually have not.
Okay, well,
but I'll take your
that's
word
probably
for
good
it.
since you're not a gynecologist.
Right.
But gynecologists know what this looks like. But the same thing happens
And
inside
that's
your
a technical
bladder.
term, old lady bottom?
No,
Oh.
it's my term. So, so we look inside the vagina if we can, but sometimes we have to use these teeny tiny little speculums on people who have this.
'Cause you can't stretch it without
hurts
tearing
too
it.
much
Yeah.
to even do a pap smear. But the bladder's doing the same thing. The urethra gets very pale. It's not pink anymore. It gets almost white and scarred, and the lining of the bladder looks the same. It's very pale.
Yeah.
No blood flow. Okay. Blood flow comes from estrogen and testosterone bringing blood flow there.
Right.
So everything on the business end of things looks very dried up, and people come in and say that this is awful. I mean, I can't, I burn when I urinate and all these infections. So my answer to that, even before I started doing pellets, was estrogen creams, estrogen patches, and I didn't have testosterone to help me.
Okay,
However,
so maybe this is an off-the-wall association, but I'm real curious and I want to ask it. If women dry up and become brittle because there's a loss of blood flow, then estrogen works in women the way Viagra works in men, and it increases the level of blood flow to that area and makes it more functional and malleable. Am I understanding that correctly?
Yes, in some ways. No, in some ways it does. But that's not the only thing estrogen does.
No, I understand that, but that was trying to just make connections that helped me get the picture overall.
Estrogen for the vagina and bladder is like an anabolic kind of steroid. It thickens things.
Okay.
And makes them look young again.
Okay.
And makes them functionally young again.
Yes.
So the irritable bladder that's always doing this is irritated for a good reason. It's really thin, and it's being attacked by the urine and bacteria, and it ends up just spasming. We talked about a cystogram. Is a test that really looks bizarre. You sit on a chair, and they put a sensor into the vagina and the bladder, and then they put fluid into your bladder and watch it expand, and then if it starts doing this, it shows up on a graph.
Right.
And then we know you have a irritable bladder. If it does this and this, and also just floods out, because spasming bladders, a little bit comes out at a time. Usually it's not just a full emptying.
Right.
If we see it just flood out, then you may have a combination. God forbid you can have a combination of these things.
Right. Where
you can have a bladder that's falling down, and you can have a bladder that is irritated as well. So you have to, my answer to this is treat with estrogen and testosterone, and I choose pellets because they work more like bringing you back to a normal level for when you were 35. Make sure your doctor gives you normal doses of estrogen if that's the only thing he has at hand or she has at hand, because if he gives you the lowest dose possible, it's not going to work because it's still going to be a thin bladder. It's not a good test. You have to have decent amounts of estrogen or testosterone or both to bring yourself back to health.
So you would say that the point of giving a woman estrogen is to restore that 60 to 150 range for them?
Yes.
And
to
if
get
you're
a
giving
blood
less than
level of
that,
60 to 150.
And if you give less than that, it's not really an effective dosage.
Yeah, it's not going to work for this. It may stop hot flashes, but it's not going to work for your bladder and all the other tissues in your body, including your skin.
Okay.
It's not going to thicken your skin and make it look young again.
Okay.
So, but for this, once you figure out which it is, or if it's both, the hormones are going to fix a lot of it by giving you back the hormones that you need, and then you can see whether you still need surgery or not.
Okay. So do the hormones first.
Right.
And that may take care of it.
Right.
Yeah, because all surgeries are dangerous. I mean, they're all risky.
And they're never as good as God gave you in the beginning. When you get a bladder sling, they save you from stress incontinence, and they're wonderful.
A bladder sling?
Bladder sling is where they put it looks like a shoestring through tiny incisions in your lower abdomen, and then they pull your bladder up and tie them, and then close the skin.
And they leave them in there?
Yeah.
Huh.
We leave a lot of things in there. We do grafts on the heart and the aorta, and I mean, they should be made of something that does not react with the human body.
Yeah.
And so in general, that's what we use. I don't do that procedure. That's a urology procedure.
So the body won't attack it?
Right.
Okay.
And it scars in, and it brings the neck of your bladder up so that you can be continent. But it's never perfect.
Yeah.
I mean, what we had before childbearing and what we have after, it's never going to be exactly like before we had children.
It's not going to improve on the way God made you.
Yeah, it's kind of like, you know, your breasts are never going to look like they did before you had children, even if you get implants. It's not going to be the same. So I'm not saying not to have children. I mean, I have a child.
Or breast implants.
Or but I am trying to get across that those are things we do as women.
Right.
And that's our sacrifice for having children. Mm-hmm. So we should be appreciated for that.
Well, but I think you also are making the point that the improvement needs to be more than cosmetic. The improvement needs to be systemic. And that comes with replacing the hormones rather than making some surface level cosmetic intervention.
That's true. And it's anatomy and physiology. For this problem, in general, you have to provide both. Anatomy is how we're made and how we're put together, and we're trying to restore the original anatomy.
Well, and let's remind...
physiology is the chemicals and the hormones and the things that circulate. Go ahead.
Well, let's remind the women who are watching who it is that we're talking about. We're talking about primarily a population of women that are over 40 or postmenopausal who have had vaginal deliveries. And those women invariably are going to develop incontinence problems of one kind or another. Now, other women may get incontinence problems. They may get them because they have the irritable bladder. They may get them because there's a stress problem due to other medical issues.
Even if they're very obese, they can get, and never had a child, they can still get bladder incontinence because the pressure pushes. But I didn't even address that yet.
No.
Or I didn't address it at all.
So it is more broadcast than we are talking about, and there are other causes of the same issue, but it's particularly focused on this singular population of women who have had multiple vaginal deliveries, or even a single one, especially if the baby was large, and who are postmenopausal or over 40, they will start to have these problems.
That's right.
And when they have them, we want them to know what's going on, that it is normal. It doesn't mean they have cancer, they're dying. It is normal, it is to be expected, and it is treatable. And it's treatable in a hierarchy of interventions. The least invasive, least expensive one is hormone replacement. So you try with hormone replacement. If that satisfies the problem, end of the game. If that doesn't satisfy the problem, then you move to a surgical consideration or some additional.
And to a urologist in general.
Yeah.
Usually there are a few gynecologists that are urologically trained, but most of the time you're going to go to a urologist.
Right. All right. So if we have not covered all of your information needs, you can contact us and let us know that, and we'll come back and revisit this topic or any of the topics that we've presented in our various podcasts. You can always reach us with that query by...
At podcast@biobalancehealth.com, or generally at the website. You can contact us at biobalancehealth.com or call my office at 314-993-0963.
And you can always reach me at brettnewcomb.com.